All right. Well, thanks everybody for the opportunity to speak this afternoon. I was mainly tasked with talking about the randomized controlled trial that we are conducting, posterior fossa decompression with or without Duraplasty for Chiari associated with Syringomyelia. So I am going to go ahead and talk about that in some detail. If there's time at the end, I thought I might also briefly update everyone on a project that we've been conducting through funding provided through ASAP, and obviously we're very excited about that. So I was hoping to quickly talk about that at the end if there's time. Don't allow me to run over. So everyone in the room is familiar with the long-standing question of whether or not to perform a Duraplasty in the setting of Chiari malformation. And this slide just kind of summarizes the two sort of broadly classified variants in terms of how we treat this from a surgical standpoint, whether we remove the bone, the suboccipital craniectomy, and perhaps the lamina of C1 or below, individualized, of course, on MRI scan. Remove the ligaments and constricting bands there that are located epidurally. Or do we do that second, more invasive phase where we open the dura, do a series of intradural maneuvers, and then close the dura with a graft? And so this question of whether or not to perform a posterior fossa decompression or a posterior fossa decompression with Duraplasty or PFDD is one of the most controversial questions, not only in this community, but amongst all of neurosurgery. And I recognize that this is too fine a print to be read. The point of this slide is to say that even 20 years ago, somebody, Susan Durham, whom you may know, worked to summarize the data at that point and see if we could perform a meta-analysis, which is really a large synthesis of the data that's out there to answer the question of whether one or the other of these is more suitable for the treatment of Chiari malformation. So that was 2008 and references data, 10 and 20 years before that. And then again, last year, there was another meta-analysis to see if we could address this question, again, this controversial question about whether or not to open the dura and perform a Duraplasty. And of course, both of these meta-analyses demonstrate what we had all suspected, which is that the Duraplasty itself may be associated with higher rates of neurological complications and cerebrospinal fluid leak, pseudomeningocele, that collection of fluid underneath the scalp back there at the surgical site, a infectious or aseptic meningitis or inflammation of the spinal fluid layers, and certainly adds to the operating room time of the surgical procedure. But there's the other part of that is, does it confer some benefit in terms of a higher rate of clinical improvement or more efficacy from the surgical side? And again, sort of talking about the various papers that have been published out there. Here's one from Todd Hankinson and Jay Wellens, where they essentially concluded, after reviewing all the literature, that a prospective randomized controlled trial would be necessary to answer this very controversial question. Again, this is nearly 10 years ago, and then this year, actually, out of the Mayo group, they concluded the same thing after reviewing all the literature, that a randomized controlled trial would be necessary to answer this question. And so back in 2011, I was fortunate to be involved in the development of a multi-center research group called the Park-Reeves Syringomyelia Research Consortium. This was created with a sizable philanthropic donation, and the idea was to bring major centers across North America together to study pediatric Chiari and Syringomyelia. The idea was to be multidisciplinary, not just neurosurgeons, but orthopedic spine surgeons, family representatives. We have physical therapists involved and nurse practitioners who run headache clinics and neurologists. So really multidisciplinary. And the goal was to accrue data, both retrospectively and prospectively, on 1,000 patients with both Chiari and Syringomyelia. So Chiari alone we don't necessarily log in here, or Syringomyelia alone we don't necessarily log in here, but it's really that sort of intersection between these two disorders. And leveraging that infrastructure about 5 or 6 years after it was up and running, we applied for funding through the Patient-Centered Outcomes Research Institute, or PCORI. Now, PCORI is an organization that was initially created through the Affordable Care Act, and the idea was to focus not just on the scientific questions, but certainly do that as well, but also to look at and involve patients and advocacy organizations in how we conduct trials. And the idea was to at once answer important scientific questions, but make sure that we were tailoring our questions to those that concern patients most. And so that's how we put this proposal together. And it was endorsed by a number of different advocacy organizations, and as well as the American Association of Neurological Surgeons, the Congress of Neurological Surgeons, and the Pediatric section, the joint section amongst all those groups. And we designed this trial as a cluster randomized control trial. So maybe I'll just take a second and describe what that is. So a randomized control trial is generally done where a participant agrees after a long consent and informed consent process, agrees to participate in the study. And in the operating room, or certainly just before the operating room, there's either a coin flip or an electronic coin flip where there is a randomization in the operating room typically where the decision was made how to, which operation to perform, the PFD or PFDD. Now for a number of reasons we chose to go with a slightly different kind of design. Mostly from the input we had from our patient partners, that sort of uncertainty would increase the anxiety at the time of surgery rather than allowing people to feel comfortable. And so the cluster design is a design in which one center is relegated to one procedure. So center A may be randomized to perform posterior fossa decompression, and center B may be randomized to perform the Duraplasty. And so all the patients that enroll and are involved in the study at that particular site get that particular operation. Now, of course, it's up to the surgeon and a panel of experts to decide that either operation is an acceptable option in that particular case. So that's all what we call adjudicated or judged to be that somebody could equivalent or could undergo either one of these procedures equivalently. The idea was to identify the surgical approach, which of those, the PFDD or PFD, that minimizes surgical complications and potential harm to patients. That was objective one. To maximize symptom relief and resolution of syrinx. That was objective two. And most importantly, to provide the highest quality of life. And the idea was to really establish that paradigm shift away from single institution or single surgeon centers and experience or recommendations without great, strong data, and even the meta-analysis that attempt to sort of assemble all that data in a logical way. This was designed to be the final answer to that question of whether Duraplasty ought to be performed. And so this is a listing of the different sites that are participating in the trial. There are 42 sites that are participating. And again, the first aim was to look and see if we could identify which of these was associated with fewer surgical complications. And so we looked at complications that occur in the first year after surgery. So those would include different things like cerebrospinal fluid leak, pseudomeningocele, the meningitis types that I described, and requirement for additional surgery, for example, a revision surgery or a shunt or other diversionary procedure for fluid. The second objective was to determine if not doing the Duraplasty, the PFD alone provided non-inferior or was no worse in terms of its ability to help clinical symptoms and help eliminate the syrinx compared with PFDD, the Duraplasty operation. And again, we looked at MRIs afterwards and all sorts of different parameters, including revision surgeries. So for example, if somebody has the PFD and doesn't develop complications but then goes on to get the Duraplasty, we would be tracking that. And lastly, and again, I want to say that this is most important amongst the people who were involved in creating the trial, is quality of life. And so the idea is, well, if one has fewer surgical complications but requires an extra surgery, does that create a better quality of life? Or are the complications so devastating that they also create a limited quality of life? So really trying to parse out which of the operations and the course that occurs afterwards would be associated with a better quality of life within this trial at 1 year postoperatively. The participants in this trial were to be less than or equal to 21 years of age, to have, and we just arbitrarily picked 5 millimeters or more of tonsillar position below the level of the foramen magnum, and the Syringomyelia less than 10 millimeters in diameter. There were a number of other exclusion criteria, basilar invagination and clival canal angles, which are acute, and these really sort of belie a more complex problem at the craniovertebral junction. So we excluded those patients from this particular study. And so from a radiological standpoint, we are looking at tonsillar position, syrinx diameter, syrinx length, and then some of these individual skull base and craniovertebral junction parameters like the PBC2 or clivus canal angle. We did collect information on dynamic studies like flow studies, the Cine flow studies, and then ventricular size as well. But what we really focused on was quality of life. And this particular paper was published 2.5 years ago, and the reason I'm bringing it up is because this was funded through ASAP funding, which was provided to our group several years ago. And so this was really exciting to us because what we did is we went through all the literature that had been published in Chiari and Syringomyelia, not necessarily pediatric, but across all age groups. And we found out that the most common outcome that papers were reporting, so our scientific literature was really reporting more than anything the physician gestalt, whether the physician felt like the patient was better after surgery. Now, I'm a neurosurgeon and I feel like I'm very thorough in the clinic after surgery, but I'm not sure I'm able to capture every bit of quality of life information in the brief time that I'm in that room checking on somebody after surgery. So to have me judge whether somebody's quality of life was improved after surgery, even though I'd like to believe I'm thorough, is probably it's not the best way to judge quality of life after a Chiari surgery. So there were a number of different groups that had used generalized scales that help to judge quality of life. There's the SF-12 and 36, the short form questionnaires, and there were a limited number of Chiari-specific questionnaires, but for the most part, almost all the papers involved sort of the physician sort of eyeballing if the patient was improved after surgery. So we partnered with a group at Vanderbilt led by Shevis Shannon and Jay Wellens, and they had just developed this instrument called the CHIP, which is the Chiari Health Index in Pediatrics, which looks at a number of different areas to assemble a health-related quality of life value. And they looked at pain symptoms in a number of different domains. They looked at non-pain symptoms. So for example, if somebody was having a hard time lifting or writing or having difficulty getting dressed, for example. And then they looked at psychosocial and developmental outcomes. So was somebody able to attend school at a set rate of frequency, or were they missing school, or were they missing work? And so Dr. Shannon, with her team developed this instrument, the chip, and so we used the chip and then another more generally accepted quality of life tool called the HUE-3 to help us understand quality of life in these patients in the trial. And again, this is not meant to be read in any detail, just to know that we standardized the workflow from the preoperative state through surgery and in the follow-up, and there are set time points for follow-up questionnaires, the chip and so forth, and follow-up MRI scans. We did modify early on the syrinx size. We wanted to make sure that surgeons would feel comfortable performing either operation, and this concept of equipoise, meaning that as a field or as an individual, but as a field, we're not really sure which operation is best. And at the extreme limit of syrinx, we felt like there would not be clinical equipoise, and most people might offer the Duraplasty, likely because of the possibility of neurological complications if a patient continued to develop Syringomyelia. So after a process of a Delphi process by which we involved expertise from a number of different centers and levels, we ultimately settled on syrinx size from 3 to 9. So less than 3 was felt sometimes to represent maybe a dilated central canal and maybe not be true Syringomyelia. And beyond 10 people, we felt like wouldn't feel like there was this concept of equipoise and comfortable randomizing patients into this trial. The other thing that sort of caused a pause at the very outset of the trial was that, as you all know, human studies research is something we take very, very seriously, and we rigorously look through our documentation to make sure that we are adhering to all the different rules and regulations about human studies research. And in order to do that across such a large number of sites, to make sure we were all using the same documentation was presented a challenge. And at the time that this trial was initiated, there was just developing a notion of a central IRB for a large research group where the lawyers and institutions could negotiate what's called a master reliance agreement, where if a amendment to the IRB, the Institutional Review Board documentation, could roll out across all centers at once. And that took about 6 months to establish. So we did have a little bit of delay at the beginning of the trial related to those two things. And as I mentioned, I think one of the most novel and exciting parts about this trial is the engagement of all sorts of different groups from all sorts of different expertise and the patients themselves in this trial. So we, as part of engagement of the community, what I'm doing here right now, I would consider engagement of the community, which is letting everybody know where we are with the trial and soliciting feedback. So please feel free to tell me or ask me any questions about the trial. We also present at other organizations, advocacy organizations as well. We've created local chapters at the major sites, which are St. Louis, at Washington University at St. Louis, and at Vanderbilt, in order to sort of make sure that we have constant and continuous feedback from patients that are affected by this condition to make sure we're answering and addressing the questions that are important to them. So I think that that is very different than a traditional clinical trial, which might be totally delineated by the investigators without any real outside feedback. So this is a unique aspect of PCORI and their studies. Related to that, this is just one example of what we do locally in St. Louis. We have a workshop coming up in a couple weeks called The Art of Effective Advocacy, and this is just one example. We try to do it at least 2 times a year. In this particular situation, we have 2 experts to help talk through, and I noticed you actually have very well-known experts here on the agenda here to help with advocacy in your school system as you transition from, for example, elementary and high school into an independent adult life. So I was very impressed to see that on the agenda as well. So these are some of the things that we're dealing with locally as well, all part of this PCORI supported trial. Of course, we expect the trial to end at some point, but we're going to continue these things going forward because we believe so strongly that they help with the interaction and interplay between medical providers and making sure patients get what they need for longevity. So this is our trial enrollment, and we enrolled somebody yesterday, so this is hot off the presses from yesterday. And we have 147 patients enrolled. This is really exciting because our target is 148. So we've got special permission from PCORI to continue to enroll all the way through the end of the year because we have been fortunate to make up that initial 6-month delay and be able to hit our enrollment target. So we're going to keep enrolling at select sites even beyond the 148, and I hope to hit that 148 in the next week or two. So this is, if you think about this, this is over 40 different hospitals and institutions contributing to this, and it's really remarkable actually that we're able to get all these patients enrolled, and we're going to finally be able to answer that long-standing question regarding Duraplasty. Along the way, I think we'll be able to address many other questions. We'll provide new and important observations about health-related quality of life and other aspects in this population, which have maybe been done retrospectively but not prospectively. Our designs on this is to continue to watch this patient cohort over time, not just for a year, but on into the future. What's it like as they transition to adulthood? After you get beyond 1 year, are they more likely to need cervical fusions or other procedures? And those are really important questions to address. And this is a very clean cohort of patients, meaning it's all being collected prospectively going forward. So we're really excited about it. One other related project is something we've been working on, and that is trying to understand the genetic etiology or basis of Chiari-1 malformation in Syringomyelia. I'm fortunate to have a neurogeneticist at Washington University named Chris Gurnett, who cut her teeth in defining the genetics of adolescent idiopathic scoliosis and club foot. And the intersection between the nervous system and the skeletal system is really important for Chiari and Syringomyelia, as you might guess, but also abnormalities of the skull base. And we have partnered with a number of institutions, as you can see here, to help work through this. And there have been a number of studies where people have looked at a subset of genes, of targeted genes. This is a different kind of technique called whole exome sequencing, where we are sequencing the entire complement of DNA in an individual that's being expressed or being used to create proteins and other things important to the body. So we have finished over 400 now, and our goal is to get to 1,000. We won't stop at 1,000, though. That's just the point we're going to stop and see what we have. So we're busily working on this as well. So I'm going to stop there. Like I mentioned, I do want to talk for a moment about this other project that ASAP funded for us, and we're grateful for that. But maybe I'll stop here and see if there are any questions first. Okay.
Thank you, Dr. Limbrick. This is the kind of effort that this profession and field needs. So you saw how carefully thought out, you have to be poised, you learn about it, and those kind of things. We talked the other day about sort of our approach to Duraplasty in the 14 and older population. And I just wanted to confirm, the concern is that in the younger population, the risks of CSF leak and meningitis seem to be, I can imagine, as a 5-year-old, seem to be higher than the adult, and we're trying to answer what the right question, what the right treatment is for this pediatric age group.
Right. Well, I can answer that. The best answer, I'll tell you what the best answer is, and then maybe a near-term answer. So the best answer, I think, is going to come from the study here, and we'll be able to examine different age groups and to see what the relative risk among different participants is. Almost all the participants in the study are less than 18. There are 1 or 2 in that 18 to 21 population, but the vast majority will be able to scale and see if we can answer that in a sophisticated way with a subgroup analysis. And that's part of the reason we're excited to go beyond that 148, which was the initial target, because I think that if we can enroll another 50 beyond that, it will really allow a robust analysis to answer questions. I've heard you mention this, and then the other person who I've heard talk about this is Jerry Grant and others, an age dependency to the complications. The more proximal answer I can tell you, as part of putting this grant together, and we have a number of other things coming out of Park Reeves here at the moment. I do happen to have in my mind the exact number of complications for the Duraplasty across all comers. So this is not relative to any sort of age separation, but this is just 0 to 21%. And it is exactly the same number that the Durham et al. Meta-analysis actually observed, which is somewhere between 17 and 18%. That's a high rate, but that also includes things that are not necessarily surgical, like a self-limited aseptic meningitis or a pseudomeningocele. The rate of complications in the non-Duraplasty was a little bit higher than we expected, related to wound infections or wound dehiscence. And I don't have that exact number, but it's somewhere between 5 and 7%, and we expected it to be on the order of 2.5%. So the differential is still there, perhaps not as great as what we thought. But age dependency is going to be critical. Yes, ma'am. Thank you. Yeah, that's an excellent question, and so it turns out that the cluster randomized control trial is 6 patients per center, understanding that not all centers would be able to make it through that regulatory gauntlet of getting all the IRBs and things done. The way that has played out, we've targeted 6 in every group, and many groups have made 6. Others are in the range of 2 or 3. And so when I said that we're going to continue enrollment in select centers, I wasn't necessarily going to get into it, but this is exactly why. So those patients who've already enrolled their 6 will stop as of the moment we hit 148, probably next week. And the other centers that have enrolled 2 or 3 will enroll to get up towards 6. That's a great question. All right, so again, I do want to thank ASAP for helping to fund this next research project. They have actually funded quite a bit of research for us over our group in Washington University over time, and a lot of the preliminary information we used to fund that larger trial that I just talked about was born out of research funded through this group. So I want to say thanks for that. I think in the end, we ended up publishing 7 papers with funding through this group. So again, I want to thank everybody for that. This particular project was funded last year, and we submitted it because we started to notice that maybe there were some discrepancies as we were starting to look at some of the information in socioeconomic and demographic factors. And we started to ask the question, could these factors be influencing how the healthcare system in general is able to help everybody in our community? And there is a precedent for this kind of research. AIS, or adolescent idiopathic scoliosis, has sort of been a leader in looking at these factors and how they influence care. This paper in 2013 from Nuno et al. Showed that there was various factors, including race and socioeconomic status, that affected access to health care, disease severity at presentation, meaning when somebody came into your office, and then also complications. I'm sorry if that's a little, oh, I know, I can see the problem here. There we go. But there's been relatively little work in this field with regard to Chiari malformation with or without Syringomyelia. There are a few papers. This is a pediatric paper here that you can see from 2015, and they use the nationwide, or the kids inpatient database. Now, that's an important factor because the kids inpatient database looks at the inpatient stay but doesn't necessarily have a linking algorithm to allow a longitudinal assessment of complications, for example. But based on the kids inpatient database, there did seem to be some discrepancies. So, for example, posterior fossa decompression with Duraplasty was performed more often in non-Hispanic whites. And there seemed to be a discrepancy in baseline health care because non-Hispanic whites tended to be admitted emergently less often than others. So in order to address this question with the support of this group, we used the data that was already existing in the Park-Reeves database. And as I mentioned, there are 1,500 patients in that database, but what we did is we looked at those patients that had imaging data available and had at least 1 year of follow-up. And we time-stamped this data last year when we initially put the proposal in, so if we were to rerun the data for now, for example, it might actually have slightly bigger sample size. And the objective of this study was to assess how sex, gender, sex, race, ethnicity, and insurance status affected the health care available to patients with Chiari and Syringomyelia longitudinally. So we looked at a number of different parameters and preoperative characteristics, what and how many radiological radiographic studies were performed. We looked at intraoperative characteristics, including blood loss and complications, and then we looked at postoperative characteristics as well, and you can see that we looked, for example, at the number of follow-up visits and how many MRIs were done, for example, after surgery. And when we looked just first at the participant characteristics overall, you can see that the age at diagnosis did not vary by sex. The time from symptom onset to diagnosis was slightly shorter for females, probably due to the comorbid scoliosis that prompts evaluation on routine evaluations oftentimes. And females did have a statistically elevated risk towards a holocord syrinx, which is a syrinx involving the entirety of the spinal cord. Interestingly, there was a bimodal distribution with peaks at 7 years and again at 12 years. And when we look at the demographics of this patient population, you can see that over 85% were non-Hispanic white, and that's a high proportion. There was an increased tendency for non-Hispanic whites to have private insurance versus Medicaid or other non-private insurers. Interestingly, when we compare males and females, there was an increased risk of back pain and, as you could guess, scoliosis in females. There was also an increased tendency towards a longer syrinx in females relative to males. When we look at non-Hispanic whites versus whites, you can see that there were more neurological deficits in the non-white population. I'm going to comment on that later, but you can see that there are differences in the presenting characteristics from ataxia, which is a balance difficulty essentially, and nystagmus, which is an eye movement abnormality, and incoordination or dysmetria. There was also a difference in the timing of surgery for non-Hispanic whites versus non-whites, and you can see that that was statistically significant with the non-white population having surgery over 2 years later on average. You can see that there was a difference in length of stay. While the range was overlapping, non-whites typically had a longer postoperative stay after surgery. Their operations took longer. They had longer estimated blood loss. And fortunately, there was no difference in complications, as you can see, going downward through the list there. There was, interestingly, no difference by race for follow-up imaging or visits or complications or any differences or changes in radiographic improvement. There was no difference by insurance status for any of these parameters, which was reassuring. So as we conclude from this very brief overview of the project, non-white patients were more likely to have neurological symptoms such as cerebellar and visual symptoms. They were also more likely to have skull base abnormalities like platybasia and basilar invagination. This next point is important. Non-white patients were 2 years older at the time of diagnosis and surgery for Chiari and Syringomyelia. They were also more likely to present with post-decompression hydrocephalus. And non-Hispanic whites were more likely to have a shorter length of stay, less blood loss, and shorter time in the OR. As I mentioned, there tended to be no difference by insurance status, and this is, I think, maybe an artifact of the fact that we were mainly looking at children who were very often able to obtain Medicaid or other non-private insurance, and the general practice of caring for these patients at regional centers. So, in conclusion of this second project, socioeconomic and demographic factors do play a role in the management of these patients. Race affects age, timing of diagnosis, length of hospital stay, while insurance status seemed to really only affect the length of hospital stay. And so we believe that the examination of socioeconomic and demographic barriers is really critically important in understanding how we can better provide access to everyone in our community for these problems. And I think this is an important role of groups like this and us as healthcare providers to make sure everybody has access in a timely fashion for healthcare in this arena. So I'm going to stop there. Again, thanks very much. I'm happy to answer any questions.